afternoon, and welcome to today's hearing, the oversight concerning recent changes to the health care benefits of the city's retirees and their dependents. My name is Idanique Miller, and I am the chair of the New York City Council's Committee on Civil Service and Labor. Welcome everyone to the People's House. We've been joined by Council members Denowitz, Moyer, and Lewis. Today's hearing will mark the fourth of the city's oversight hearing on healthcare savings agreement entered into by the administration and the Municipal Labor Council. Since our last hearing topic in 2018, the city and the Municipal Labor Council Committee reached an agreement to adopt Medicare Advantage plan. Under this plan, the city's retirees would be switched from their current benefit plan to a new Medicare Advantage plan that will be jointly administered by private health insurance companies, Emblem Health, and Blue Cross Blue Shield. Throughout these hearings, I have shared my concerns about the cost savings measures have limited access and diminished quality of care for the city's municipal workforce. New York City retirees earn and deserve access to superior service and efficient delivery of services. We need to address the city's escalating healthcare costs without sacrificing benefits and service to its city's most precious resources, their retirees. Today we will hear from the city's Office of Labor Relations and the Mayor's Office of Budget and Management and Budget about the New York City's new Medicare Advantage Plus plan. My goal for today's hearing are to evaluate the new plan and to learn more about the city's effort to educate retirees about the expected new benefits and the changes, if any. Today's hearing is also an opportunity for the administration to correct the record about any misinformation about New York City's Medicare Advantage Plus plan and to address retirees' fears about the impending changes. I'd like to thank my staff, Chief of Staff Ali Rasul-Najad, Legislative Director John Wani, and of course, my senior advisor, the great Joe Goldblum. I'd like to thank legislative staff as well, Committee Counsel Bianca Vitale, Policy Analyst Elizabeth Arts, and Finance Analyst Nevin Singh. With that, we will now hear from the administrative witnesses, Commissioner of New York City Office of Labor Relations, Renee Campion, and the Office of Labor Relations Deputy Commissioner of Healthcare Strategies, Claire Levitt, and First Deputy Director of Office of Management and Budget, Kim Gardner. Council, can you affirm the witnesses?
Good afternoon. Do you affirm that your testimony will be truthful to the best of your knowledge, information, and belief?
I do.
I do.
I do. Chair?
Okay, you may begin your testimony.
Thank you, Chair. Can you hear me sufficiently with the mask on? I just want to keep
Yes, we can.
Mask on? Okay. All right. So good afternoon, Chair Miller and members of the Civil Service and Labor Committee. Thank you for the opportunity to testify here today. I'm joined at the table by Claire Levitt, OLR Deputy Commissioner for Healthcare Strategy, and Ken Gardner, First Deputy Budget Director. We're here today to discuss the new New York City Medicare Advantage Plus plan that was customized for the 250,000 New York City Medicare retirees and dependents. The city has worked hard in collaboration with the Municipal Labor Committee to offer a new retiree health plan that is not only premium-free with benefits equivalent to the existing senior care plan, but also provides important new benefits designed to support the health of our retirees. We understand that retirees have questions about this plan, but we are very proud and excited about what this plan offers, and we hope to offer clarification during this hearing today. By converting from a Medicare supplemental plan to a Medicare Advantage plan, the city will benefit from the federal government subsidy of Medicare Advantage plans nationwide and will save $600 million a year while still providing an even better plan than the current plan. As you may be aware, pending litigation may limit our ability to answer some questions, but we will do our best to have the most productive hearing possible for the benefit of the retirees who are here with us today, as well as the council members present. The court has extended the opt-out deadline, and we will be submitting an implementation plan to the court for review. We hope we'll receive permission to move forward with the implementation of the plan expeditiously. How original Medicare and Medicare Advantage plans are different. To understand how Medicare Advantage plans generate savings, it's important to understand how traditional Medicare and Medicare Advantage work differently. In traditional Medicare, the Centers for Medicare and Medicaid Services, CMS, directly pays hospitals under Medicare Part A and also directly pays medical expenses to doctors and other healthcare providers under Medicare Part B, which generally pays 80% of the Medicare allowable rate. A Medicare supplemental plan like Senior Care pays after Medicare pays and covers the 20% that Medicare Part B doesn't pay, subject to any copays in the plan. Medicare Advantage plans, sometimes called Part C, are offered by Medicare-approved private insurance companies. In a Medicare Advantage plan, both Part A and Part B payments come from the Medicare Advantage plan, not original Medicare, along with the supplemental benefits from the same company. A Medicare Advantage plan typically includes benefits not covered by Medicare. The process is seamless, so it's simpler for retirees. Our testimony includes some helpful visuals that highlight some of these key differences, and that is in your packet. Medicare pays a fixed amount for coverage each month to the company offering the Medicare Advantage plan. Under Medicare Advantage plan, the private company must follow all of Medicare's rules, and a retiree has all of the same rights and protections that retirees have under original Medicare. Medicare Advantage plans are able to provide better and more efficient programs, address care gaps, and support the health of the program's members with the amount of money provided by Medicare, and may need to charge an employer little or no additional premium. About 42% of Medicare recipients nationally receive their Medicare coverage through a Medicare Advantage plan. To review why we embarked on this change, in 2014, the city and the municipal unions entered into a four-year agreement to achieve $3.4 billion in guaranteed health cost savings aimed at controlling the escalating costs for New York's healthcare programs. As reported to this committee previously, we achieved those savings in the 2015 to 2018 period. In 2018, we agreed with the Municipal Labor Committee to target another round of savings for 2018 through 2021 of $1.1 billion, which we have also achieved and will be fully reporting on shortly. It's important to note that the Medicare Advantage savings are not part of our health savings program targets. Instead, in an agreement with the MLC, the city agreed that the full amount of the Medicare Advantage savings, expected to be about $600 million a year, would be redirected to support the benefits provided by the Health Insurance Stabilization Fund for actives and retirees. The Health Stabilization Fund was originally established in the 1980s to ensure that there was funding to equalize the costs of the PPO plan and the HMO plan to permit employees to have a choice. Over time, it has also covered other important expenses, including specialty drugs, care management, and other costs. The Stabilization Fund is jointly administered by the city and the MLC. As part of the 2018 agreement, we also established a tripartite committee consisting of leadership of the Municipal Labor Committee, the city, and arbitrator Marty Scheinman to work on identifying additional cost management strategies. During the 2015 to 2020 period, all the savings programs involved changes to the healthcare coverage for active employees and pre-Medicare retirees. With the tripartite committee, the city and the MLC also began exploring changes to the Medicare retiree coverage. New York City retirees, like New York City active employees, enjoy premium-free health insurance coverage. In addition, the city reimburses retirees and their spouses for the coverage of Medicare Part B coverage. These are increasingly rare and unusual benefits, and they are very expensive. Since 2000, the cost to the city for retiree health coverage has nearly tripled. In 2020, we spent $571 million on retiree health coverage compared to $200 million in 2000. In addition, the reimbursement of Medicare Part B coverage for retirees has gone from $54 million in 2000 to $382 million in 2020, an increase of over 600%. In 2020, the city spent nearly $1 billion on retiree health costs. There are some bar graphs in the testimony that represent in 5-year increments the different escalations in costs. Knowing that the escalating cost of retiree benefits needed to be addressed, in early 2020, the MLC and the city agreed to add $15 copays to certain benefits in the senior care plan for doctor visits, radiology, and lab services. However, before that could be implemented in July 2020, the COVID pandemic hit, and the city and the MLC agreed it was not the right time to change retiree benefits. Instead, those copays were included in both the new Medicare Advantage Plus plan and the senior care plan for 2022. The city and the MLC worked for over a year to develop parameters for a new Medicare Advantage program and commenced the negotiated acquisition process in November 2020 to select a vendor whose offer was most advantageous to the city. In July of 2021, it was announced that the city and the MLC had awarded the contract to the Alliance, a contractual alliance comprised of Anthem, Empire Blue Cross, and Emblem Health, and that the new plan was expected to save the city about $600 million a year as a result. In developing the program, we were committed to offering similar benefits to the existing program while optimizing the federal funding available for Medicare Advantage programs. This new program is a win-win for everyone involved. Retirees continue to have a robust program of premium-free health insurance, plus their Medicare Part B reimbursements, and the city is able to save $600 million a year. Our new plan, called the New York City Medicare Advantage Plus plan, is a customized plan exclusively for New York City retirees, designed to provide equivalent or better benefits in comparison to the senior care plan and at no premium cost to retirees. The New York City Medicare Advantage Plus plan replaces both traditional Medicare and a Medicare supplement plan with a single integrated program at a much lower cost to the city than the existing senior care program, and at no premium cost to retirees. The Medicare Advantage plan provides all the healthcare services previously covered by original Medicare and those supplemented by the senior care program, and also adds important new benefits not covered by the current senior care plan. One of the most important ways Medicare Advantage plans can be less expensive is by encouraging and enhancing the healthy lifestyle choices of its participants. The New York City Medicare Advantage Plus plan is designed to motivate individuals to stay healthy with preventive programs and to improve clinical outcomes for patients with more complex medical conditions. This innovative plan includes addressing complex case management, home visits, house calls, and a rare disease management program. A comparison chart of all of the major plan provisions is on the following page of your packet. If you look at the side-by-side comparison chart of the senior care and Medicare Advantage benefits, you'll see that they are virtually identical, except that the new Medicare Advantage program offers some important new benefits not available in any of our other retiree plans. Let me name some of them. $0 copay for primary care visits compared to $15 copay under senior care. An out-of-pocket maximum of $1,470 per year compared to the senior care program with no out-of-pocket maximum, basically unlimited. 365 days of hospital coverage, only available as an additional buy-up in senior care. Transportation to and from a doctor's office or pharmacy for up to 24 visits a year. Meals provided after a hospital stay. A $500 hearing aid allowance. A telehealth with $0 copay. The Silver Sneakers Fitness Program, plus a fitness tracker device. And $200 wellness rewards programs that pay retirees to go for preventive care. You have in your packet a list of, more extensive list with more detail of the senior care benefits versus the Medicare Advantage. One of the major concerns we hear from retirees is that they won't be able to continue to see their doctor. This is not the case. This is not a limited network plan. Our Medicare Advantage plan is what's called a passive PPO plan or an extended service area plan. This means that our retirees can go to any doctor that accepts Medicare. I want to repeat it because it's important to understand. Retirees can go to any doctor that accepts Medicare. That's 850,000 Medicare participating doctors nationwide. It's the same number of doctors they can go to in the senior care plan. It doesn't matter if the doctor is actually in the Alliance network or not. Even if a retiree goes to a doctor who's not in the Alliance network, the retiree can't be balance billed above the Medicare fee schedule according to the Medicare rules. Over 91% of the providers that the retirees in senior care have utilized are providers who are contracted directly with the Alliance to accept the Medicare Advantage plan. Unfortunately, some doctors' offices are still confused by the new program, especially outside the New York area. And we've heard complaints from retirees saying their doctor's office said they don't take Medicare Advantage. To address this, the Alliance has embarked on an extensive program to educate doctors about the new program and is holding webinars for doctors to help them understand how it works. All the hospitals in the New York metropolitan area, including renowned institutions such as Memorial Sloan Kettering and the Hospital for Special Surgery, participate in the Alliance network. The Alliance has signed contracts with both Memorial Sloan Kettering and HSS. Outside of the New York metropolitan area, the National Anthem Blue Cross network covers 96% of all hospitals. Also, the New York City Medicare Advantage Plus plan does not require a referral to go to a specialist. Retirees can self-refer to any Medicare participating specialist. Retirees have expressed concerns about the pre-authorization requirements in the new Medicare Advantage plan, including whether it causes delays, creates paperwork for them, and results in denials of care. The pre-authorization requirements are actually identical to the requirements in the Empire Emblem CBP plan for active employees. So most of our retirees have been part of such a program when they were active employees. Under the Alliance plan, the pre-authorization reviews are conducted between the provider and the Alliance, and there is no paperwork for the retiree. Reviews are normally completed within 3 to 5 days. In an emergency, the requirements are waived. In an urgent situation, the time frame is 24 to 48 hours. While out-of-network Medicare providers are not required to seek authorization, members are encouraged to work with these providers to obtain pre-authorization to ensure proper processing and payment of their claims. While this is a procedural change, it guarantees that treatment is medically necessary and appropriate for our retirees and assures that they know in advance what is covered. Current New York City retirees will be given the option to opt out of the new New York City Medicare Advantage Plus program and remain in whatever program they are currently enrolled in. However, their existing program may require an additional premium. For example, to remain in the senior care program is a cost of $191.57 per month per person. Rates for other plans are shown in the rate chart in the appendix of your testimony binder. Retirees who do not opt out will be automatically enrolled in the New York City Medicare Advantage Plus plan and will have no premium cost. Retirees will have annual open enrollments during which they can transfer between the Medicare Advantage plan and the senior care plan. Future retirees will have a choice of senior care at the buy-up rate or the premium-free Medicare Advantage plan. Many retirees get their prescription drugs from their union welfare funds, and that remains unchanged on the Medicare Advantage plan. For those retirees who don't have prescription drug coverage from their union's welfare fund, the Emblem Health prescription drug rider that is currently available to those retirees will continue to be offered. The copays and the formulary remain the same, and this program does not have the Medicare Part D donut hole. The one change is that the price is being reduced from $150 a month to $125 per month. The city, the MLC, and the Alliance are working diligently to make sure retirees have access to extensive information about the new program. Retirees received an introductory letter in August and a 40-page enrollment guide in September, along with a set of frequently asked questions. All of the material, including a comparison of each existing plan with the new Medicare Advantage plan, is posted on the OLR website and is provided for you in the attachments with the testimony. The Alliance has also held ongoing webinars open to all retirees. To date, there have been 77 webinars attended by 38,000 retirees. 12 more are scheduled, and the Alliance will continue to hold webinars as long as there is demand. In addition, a recorded version of that webinar is available for your viewing at the website mentioned in the testimony. Once they enroll, retirees will receive a welcome kit and their new ID card before the start date. Ongoing monthly newsletters will keep them informed and up to date. The new Medicare Advantage Plus plan will significantly reduce the city's cost because of federal funding, while providing the same benefits as the senior care plan. Its customized features include many new and exciting quality programs to support retirees. By agreement with the MLC, Municipal Labor Committee, the city will be redirecting the savings generated by the program into the Health Insurance Stabilization Fund to help support the health insurance programs for actives and retirees. This helps the city to continue to provide a premium-free health program to actives and retirees and continue to reimburse retirees for Part B premiums. The city and the MLC are forming a committee to carefully monitor the Medicare Advantage program to ensure that the Alliance meets all of its commitments to us and delivers the quality services we expect for our retirees. The city and the MLC are designing a reporting package for the Alliance to report back to us on important aspects of the program, including customer service response times, payment turnaround time, complaints, pre-authorization information, and more. We will report publicly on the status of the program on an ongoing basis. Above all, providing high-quality, premium-free health insurance coverage to retired city employees has been our #1 priority throughout this process. Thank you for inviting us to this important hearing. We'd be happy to take any questions now from the committee.
Thank you so much. And we've been joined by Council Member Helen Rosenthal. Okay, we will begin with some questions. So let's begin by talking about how this marriage happened between the Alliance was created, and then we kind of get to where we are today, and the new plan and implementation of the new plan. But let's begin by talking about the 2018 Health Savings Agreement between the city and the MLC that committed to the establishment of the tripartite insurance policy committee to study and make recommendations for the reforming health care for city workers and their dependents to achieve long-term savings and stability. How many members serve on the tripartite health insurance policy committee?
Thank you for the question, Chair. The number of, so there is, there's a representative chair of the MLC who is the principal, and that person is Harry Nispoli, chair of the MLC and president of the sanitation workers. Mm-hmm. The city chair of the committee is myself, as the labor commissioner representing the city of New York. And the third person is Marty Scheinman, who's a well-renowned arbitrator and mediator who was named in the prior agreement from 2014 to address any issues that came up as a result of the health savings benefit agreement. There are many other people, including my deputy commissioner for healthcare cost management, Claire Levitt, Ken Gardner, the first deputy budget director on the city side. Also on the city side is we have an actuary from Milliman who attends every meeting. On the union side, there are various members of the health technical committee and members of the different principals of the unions, Henry Garrido from DC 37, Michael Mulgrew from the UFT, as well as their represented actuary from the Siegel firm.
Okay, so, and basically, they're appointed by the MLC as well as the administration? Would that be correct?
Well, thank you. The city appointed its own chair. The MLC appointed their own chairs. And Marty Scheinman the parties agreed that Marty Scheinman would be the third person chairing those meetings.
Okay, my old friend, Marty. Okay, were they obvious factors in determining who these individuals were based on qualifications?
So the
or just
since
was it a matter of titles?
Well, I don't. It was really a matter of who the principal was representing the chair, the committee itself. Though, you know, on the MLC side, obviously the three principals, Harry Nispoli, Henry Garrido, and Michael Mulgrew, are all there and present for all meetings.
But the representative on the actual committee is three, right? That's
the Harry Nispoli from the MLC, right. Myself for the city of New York, and Marty Scheinman.
Okay, and the rest are technical support that are made available for each meeting on all sides, be it
correct.
Administration,
the representative at their desire, technical support, and yes, and the actuaries on both sides.
And so, how was it that the committee ultimately communicated communicated its recommendations to the city and the MLC? Was it verbal? Was oral? Was it written reports?
We had, thank you. We had several, actually over the course of approximately 2 years of monthly or bi-monthly meetings in person, pre-COVID, in-person meetings that were held in my offices, the Office of Labor Relations, and we worked out, we had many discussions, and worked out when we came to a mutual agreement on different solutions to the sort of spiraling healthcare costs. In order to address those, we, upon mutual agreement, we agreed to pursue them.
So I noticed in you articulating who was on the panel and who was there for technical support. Were there any retirees from the collective bargaining units that were represented, or who represented retirees, or were they represented at all on the tri-panel?
So on the tripartite panel, to clarify, the discussions were not only about retirees, the discussions on the healthcare savings program are regarding actives and retirees and their families. So those were the discussions that actually encompass all
right, but
all
was
sides.
there any retirees represented? We do this, okay? Thank you.
There were no specific independent retirees that were represented on the panel.
Okay. And with the recommendations that came from the panel, the committee, were retirees ultimately able, were there an opportunity for them to review any of the recommendations?
I think it's important at this point that I just clarify the role of the MLC in the city and how health bargaining takes place.
Please.
Okay, thank you. So the city and the Municipal Labor Committee have been working together, and they have written agreements regarding the mandatory subject of bargaining of health benefits. So it's a mandatory subject of bargaining that is done, as we do in other environments, with the representative of the city team, and representatives of the respective union, in this case, the Municipal Labor Committee. There are agreements going back to 1992, where it is agreed between the parties that we are to jointly discuss and come to an agreement, essentially, on healthcare benefit savings and to discuss healthcare benefit issues. The tripartite committee that was established as a result of bargaining between the MLC and the City of New York had members on it who were part of both of those entities. So there is not, the MLC, the Municipal Labor Committee, represents employees, their respective employees, as well as their respective employee groups, and the City of New York represents the city's interests. Why don't I just leave it at that?
So I guess I would not necessarily conclude, but surmise that the MLC and other bargaining units, based on what you just said, they are the exclusive bargaining agents for benefits, according to the agreement, which includes the retiree benefits, correct?
That's correct.
And so this, I guess I would pose to members of the MLC and the unions, that they have conferred and with retirees that they represent over this. Okay, so that's further. So what criteria did the committee consider when evaluating the cost-saving options?
Thank you for the question. So, due to the fact that healthcare costs, as we all are very more than well aware of, are spiraling, increasing year after year after year, it became clear, and the parties were agreed to meet to discuss what strategies could be used to reduce the cost and continue to provide the same premium-free health benefits to actives and retirees that the city and the MLC had historically provided. There were many benefits, there were many improvements and changes that were made on the active side, as well as, until the point of the Medicare Advantage was discussed. At that point, there had not been any benefit changes on the retiree side. I'll ask Claire Levitt, my Deputy Commissioner for Healthcare Cost Management, to go into a little bit of detail about the actual benefits that the parties did agree to implement.
So I'm sorry, Claire, before, and please identify yourself on the record, but before you answer, I'm to assume that it was the continued escalating costs that kind of drove the MLC and the city towards this agreement? Because the question was...
That's correct. So I believe I mentioned in my testimony, Chair, that the increases in costs on the retiree side had gone up exponentially.
Right, yes.
600.
Yeah,
right.
600%.
And the Medicare Part B reimbursement had gone up 600%.
And we'll get to that, because what was the, at the same time period, how much did the active member escalate? What was the... how much did the active benefit increase in cost during the same time period?
Unless one of my fellow panelists has that information, I'll get back to you with that information, sir.
Okay, Claire? You're up.
Thank you. Claire Levitt. I'm a Deputy Commissioner for the Office of Labor Relations for Healthcare Strategy. In looking at our options for healthcare savings, we considered many different approaches for retiree benefits. We looked at the possibility of reducing some of the benefits that were in the senior care plan. But what the beauty of the Medicare Advantage Plus plan is that for the same, that we can get all of these savings because of the federal subsidies, provide the same level of benefits and still keep it premium free. So we were very excited to be able to offer a plan that not only created a huge amount of cost savings for the city, but didn't take anything away from our retirees, but in fact added to the benefits that they actually have. And Renee went through some of the specifics of the additional benefits in the plan, and you can see that there are a whole lot of brand new benefits, including a $1,470 out-of-pocket maximum per year when there was no out-of-pocket maximum before, and retirees could have an unlimited amount of out-of-pocket expense. It covers the 365 days of hospital coverage that was only previously available as a buy-up. And one of the benefits that really excites me is the idea that it covers transportation to and from a doctor's office, which is a wonderful benefit for retirees. There's a $500 hearing aid allowance. Retirees have not previously also had telehealth coverage, and this adds telehealth coverage with a zero copay. So we think that this is actually a superior plan to the combination of Medicare and the senior care plan, and still keeps it premium free for retirees, and also enables us to continue reimbursing everybody for their Medicare Part B premium coverage.
Okay, thank you. That was pretty extensive, but we are going to kind of drill down further with the plan, the benefits of the plan. But I know my colleagues have questions, and I think I have two before. And could you speak to the difference in this very specific employee Medicare Advantage plan that we're entering into, as opposed to private Medicare Advantage that they could opt into during any, as individuals during any annual open enrollment period? What makes this special?
So thank you, Chair, for asking that important question. This plan is subject to all of the same rules and guidelines as Medicare as it currently exists. It does not, there is no premium cost, as we've said, and that people can see, and retirees can see the same doctors under, if the retiree is seeing a doctor under senior care today, and they accept Medicare, then they can see the same doctor when this plan goes into effect that also accepts Medicare. There is, let me just, if I can make one more.
And that's the primary difference between this and what Joe Namath has to offer?
Well, so this plan was exclusively designed for New York City retirees. It is not an off-the-shelf Medicare Advantage plan that I'm sure many people are aware of and have friends and family across the country who they are in with limited networks and reduced benefits. This plan was created specifically for New York City retirees, and the cornerstone of the plan was that Medicare retirees would be able to see any doctor that accepts Medicare, and their benefits would be equal to or better than, and in many cases better than, the existing benefits.
Okay, great. That's a good segue into my next question before I hand it off. And that is that one of the criteria from your office, Office of Labor Relations, on the RFP was that the bidders have at least one client with at least 50,000 employees, unless another client had 50,000 members. In Medicare Advantage, is that Medicare Advantage, or is that employees or members represented in general?
So thank you, Chair, for asking the question. Regarding the procurement, as you're aware, the case is in litigation, and to the extent that there is argument on both sides, at this point, I'm not able to discuss the legalities of that case, but we can discuss what the current Medicare Advantage plan and the previous senior care plan enable.
Yeah, I'm not asking that. I'm just asking about the criteria for the RFP. Was it that you required 50,000 members in an experienced group in order to qualify or in order to bid?
So let me defer to Claire Levitt, the Deputy Commissioner, to the extent she has the specifics.
There was a requirement in the RFP that the bidders have clients that have 50,000 lives. The intent of that was to make sure that we had bidders who were large enough to handle the city's requirements for the plan. The intention was not to have a specific number, but just to make sure that we weren't getting bids from plans that, that were tiny plans and were not equipped to handle the operations of the city.
And all bids that were accepted met that criteria, correct?
Yes.
Okay. And we're now going to hear from Council Members Denowitz, Lewis, and Rosenthal.
Thank you, Chair. Thank you for being here, and of course, thank you, Chair, for recognizing me. I'm a little confused because what you're saying today is just a lot different than what I'm hearing from my constituents. So you said this plan has all of the same rights and protections as the previous plan. And so I'm just confused as to why I have constituents emailing me saying that their doctors aren't accepting these plans. Are you able to answer that?
Yes, I provide an answer for you, Chair, Council Member. So to the, we need to do, it's clear that we need to do a better job in educating both the providers, the physicians and other healthcare practitioners about what this plan is and what this plan is not. The Alliance and the city together, along with the MLC, are working together to make sure that we're providing as much information on a regular basis. We're meeting daily.
So let me pause there, and I don't mean to interrupt you.
Okay.
So I'm glad you're going to do a better job. I just want to be respectful of everyone's time. And so I'm then confused about the timeline of all this, right? In 2020, in 2020 you started to explore this option. But in 2014, that was when you need the cost savings. So why not in 2014 start looking at Medicare Advantage planned. Am I getting this wrong? The unions we all agreed would find these cost savings, and this seems like a magical silver bullet. More services for $600 million less every year. Why wait till 2020 to find those savings?
So, council member, it's a good question. So in 2014 was the first time that the city and the MLC had agreed to historic savings changes. It was total from 14 to 18, sorry. There were, the parties agreed to $3.4 billion in savings, and those took, those savings were divided, decided and took over, there was a significant amount of period of time to try and get to those savings. At that time, Medicare Advantage was not, I was here, I was here in the Office of Labor Relations in a different capacity, but we did not actively discuss Medicare Advantage plan, because the parties were had decided to talk about other avenues of savings. When in 2020, when the tripartite continued to meet to come up with savings, to try and come up with ideas for savings, we dug down into the Medicare Advantage plan aspect, and started talking more earnestly about where the savings could come from and how it could, where the savings could be, what would the savings could be, and but we needed to make sure that the benefits didn't change for the retirees, and the issue about the doctors and what their access to the doctors did not change. That took a lot of time to really drill down to and to really come up with some kind of program that we and the MLC were comfortable with, to even proffer, to even put out as a procurement option.
I guess what I'm trying to say still about the timeline is understand how older adults and retirees feel, and what I'm feeling from a lot of the emails and calls I'm getting is fear, right? Fear that the pension and rights, things like that, are going to be taken, not your pension,
Right.
But that's part of the pension. That's why we work so many years, right? And we know it's not supposed to be diminished or reduced, but that's how it feels when it feels suddenly out of the blue, because as Chair said, the retirees weren't represented. There didn't seem to be retiree input. Suddenly there's a new plan that what we know about Medicare Advantage plans, privatized insurance. Physicians and doctors are telling patients that they're not going to be able to see them anymore, and that suddenly they have to decide by, I guess it was October 31st. I know that's changed now, but that's sort of the communication that's been happening, and that's why you have so many people very fearful of this, and it's hard to disagree with them. It's hard to say that their fears are unwarranted because there hasn't been a two-way street of communication, and I just want to point out you keep saying that the city's going to save money, but it's really, the city's interests, but the city's interests are its residents, right? And when the residents feel as though the city needs to save money off of their backs, that's when we run into a lot of problems. And so I sure hope these plans are better for cheaper. It sounds like magic. It sounds great. But that seriously has to be communicated to all of our retirees, because I haven't gotten a single email,
Okay.
Please go ahead.
Oh, so if I could just respond
Yes, please.
on a few points, thank you. Number one, I want to say that we recognize the importance and the concerns that both active employees and retirees have about health insurance. It is very personal. We understand that. It's very, very clear. My office has gotten large numbers of emails and phone calls as well from retirees who are afraid and who are concerned. We, from the very beginnings, when we were started talking about Medicare Advantage, we did not have in the beginning, prior to 2020, a plan or a vendor in mind. There was going to be an open procurement, open competitive bid. We did not have those ideas in mind. We wanted to make sure that the benefits were the same and that they would still maintain their doctors. So when we put it out to bid in the early part of, in November of 2020, it was only at that point where when we got the bids, responsive to the procurement request, that we'd be able to drill down and to find out and make sure that what we were requiring in the bid to make sure that the benefits were the same and or better, we would go forward. We didn't know it until we received those responses, until the MLC and the city were satisfied that the benefits would be the same or better. That was our requirement, the same or better. We were not in a position at that time to discuss openly with vendors or to discuss what a particular company or a vendor could provide at that time. We understand that we have the judge's decision, the recent decision from the judge from last week, asking for an implementation plan. We are in the midst of preparing that response and submitting it to the judge. It needs to be provided to the opposing side 7 days before it goes to the judge. And then the judge will make their decision, will make his decision on how we proceed forward.
All right, I'll leave it there, Chair. Thank you.
Thank you so much, Chair Miller. Thank you, Commissioner, and the whole panel for being here. Like my colleagues that are here, I'm just as concerned as them. I get the 100,000 emails from the constituent, and I see, you had a great testimony. It painted a really pretty picture. Thank you. That's not the reality here, because while the committee comes together and creates this really beautiful picture, the reality is people feel disproportionately impacted by a decision that the committee is making. And in your testimony, you shared there were 850,000 doctors that will be participating nationwide. So I wanted to know how many will currently be participating in the Alliance's network for New York? Like, do we have that number?
Thank you, Council Member, for the question. I'll defer to Claire to respond.
Sorry, thank you. We do have that information. In New York City, there are about 37,000 Medicare participating providers, and about 34,000 of them are participating in the Alliance plan.
Thank you for that. Because also mentioned in the testimony, to just go back on your response, it was also stated that the Alliance needs to educate doctors about participating. So I'm listening to these numbers, and I'm also thinking about the testimony and educating providers. What does that look like if these providers decide that they don't want to participate? What happens to, what's the process after that?
Even if a doctor is not participating in the Alliance network, if they are participating in Medicare, a retiree can go to that doctor and the doctor is still obligated to take the Medicare allowable amount. So they really have access to every single doctor who participates in Medicare, as they did before in the Medicare supplemental plan.
But doesn't that go against the goal that you're trying to create here with this plan?
It doesn't go against the goal of the plan because the goal of the plan is to provide equal benefits to the senior care plan, but because it is through the Medicare Advantage structure, it has a federal subsidy. And that's where the savings is coming from. It's coming from the federal government paying the alliance to provide these benefits. So the doctors are obligated to take the Medicare allowable amount, whether they're in the alliance network or not. They still have to take the Medicare allowable amount, and that's what the alliance will pay them.
Okay, so if the city and the MLC fail to meet the targeted savings of the goal of 600 million for FY22, what would this cause? Would this cause out of pocket?
It's important not to confuse the 600 million savings that was the health target for fiscal 21 of recurring savings with the 600 million that's being saved in the Medicare Advantage program. We had 2 rounds of health savings agreements with the Municipal Labor Committee, one for fiscal 15 through 18, during which we saved $3.4 billion, exclusively on the coverage for the actives. And then we had another $1.1 billion target for the fiscal 19 through fiscal 21 period. And it's just coincidence that the requirement was that 600 million of it be in fiscal 21 and be recurring savings. It's confused a lot of people because they think that the 600 million that we're talking about saving from the Medicare Advantage plan is the same as the savings target, and it's not. This is something that's totally separate. There will be 600 million recurring savings for the fiscal 21 health savings targets. This 600 million that the city will save through Medicare Advantage is not actually budget savings. It's actually going to be allocated to the Health Insurance Stabilization Fund, which pays for other benefits for actives and retirees. So it's not actually city savings. We are saving the money, but the money is being redirected back to active employees and retirees through the Stabilization Fund.
Yeah, I think we could provide some more clarity about the 600 million.
But I think that's the problem, right? No one understands that. And you need to communicate, that needs to be communicated better because that's what people are asking for. They're asking for clarity, they're asking for communication and more information. I have a bunch of questions, but I'm gonna just ask one last one, and this is regarding the actual representation of the committee because people feel that it's not equitable. I wanted to know if at some point retirees would be considered to participate on the panel in the committee. That's my last question. Thank you.
So thank you for the question. Let me say that the responsibility of the healthcare program negotiations is between the MLC and the city. That is the mandatory subject bargaining requirement. I can't speak to the unions. They do an excellent job of that. But on the city side, we have to negotiate with the MLC directly. That's our obligation.
Just asking for consideration. Yeah.
I hear you.
Thank you. Just to follow up, first of all, thank you, Councilmember Miller, Chair Miller, for having this hearing. My office has been also inundated with questions, so having an opportunity for a public discussion is incredibly helpful. I just want to follow up on Councilmember Lewis's last question. Just describe this is a description thing. So it's OLR and the Municipal Labor Committee, and who makes up the Municipal Labor Committee?
So the entire Municipal Labor Committee is an umbrella organization that encompasses over 100 different public sector labor unions. It is an entity that is responsible for negotiating the healthcare insurance program, and the principals on it they have an executive board as well as the chair of the MLC, as well as each of representation of each of the different unions who are members of the Municipal Labor Committee.
Okay. A couple of quick questions before I try to understand what's happening here. I'm confused about the opt-out date. I'm getting that question a lot. What is the opt-out date?
So, Claire, could you explain?
Thank you for that question, because it is important in the context of the litigation. Our original opt-out date was set for October 31st. That has been extended, it's been extended by the court, and we don't have a final opt-out date yet until we resubmit a plan to the court.
Let me ask you a question. What does it say on your website?
It doesn't, it no longer says on our website.
Right, so your website
It no longer says on our website that it's October 31st.
Says, just to be clear, your website currently says the last day to opt out is October 31st, 2021. Could I just ask you, as a beginning, to clear up communication?
Yeah.
Can you please change that on
Yes.
your website?
Absolutely, absolutely.
Hold on.
Like,
yes,
now.
yes, Councilmember Rosenthal, yes, we will
All right.
do that and clear that up with
Great.
reference to the judge's decision.
I understand that you have lawyers in your head, but you have people who are reading the website. Even saying subject to whatever the judge says is completely confusing to me. But what would not be confusing is a sentence that said, it's been extended beyond October 31st. We do not know when it will be yet. Please log on every day to check. We will put in the date as soon as we know it. Or even better, we will put in what the opt-out date is at least a month prior to the date. Do you know what I mean? Like, just try to use real words that that resonate with people.
I understand, Councilmember.
Thank you. Second question is about your phone number. No one can get through to the phone number. Or what I should say is the blessed few who get through the number, let's emphasize the word few. So you have to have a better system. This is too big of a change to just have one line that goes unanswered for all of the constituents. I mean, you just have 4 members here who are begging you. You know, we represent, in some ways, all 51. No one's getting through the phone, and you have to come up with a better system. Do you think you should work with maybe Commissioner Tisch? How can you come up with a better phone answering system?
So let me respond. Thank you for the question. Thank you for the comment. The phone line for the Office of Labor Relations is one phone line.
And that's, yep, what number is that?
306, I believe, 7660.
It's okay, I'm not playing gotcha, but I just want to know if it's one of the 2 that I'm looking at on my piece of paper.
I will confirm that number.
Okay, the 2 I have on my piece of paper are for Medicare Advantage, call the 833-325-1190.
Yes.
And that seems to be the only phone number for Medicare Advantage. The other phone number I have on my sheet of paper is to call for all OLR benefits. The phone number is 212-513-0470. And that number also seems to be perpetually busy. If there's a third number, at some point, you should announce it in this hearing. But the real question is 3 lines, 2 lines, it's just not enough.
I hear what you're saying, council member. The number that starts with 833, that's the Alliance customer service number that was established once we determined the vendor,
And who runs that phone line?
the Alliance.
And who is the Alliance? Right, I know on paper the answer, but whoever the Alliance is, it has fallen down on the job. There's gotta be an individual. I mean, isn't the Alliance made up of, you know, the whole bunch of insurance companies, but also the city to some degree?
No, the Alliance is, no, the city of New York is not part, is not an
So
organization
who
within the
has
Alliance.
authority to tell the Alliance to have more phone lines?
We can, yes, we will speak, the city of New York can speak will speak and make sure.
I mean, is
Those
it
are
a speak or a demand? I mean, if
Absolutely.
911, if the answering to 911 was like this, you know, would not be good. But, I mean, you have 245,000 retirees, all of them are calling one number? How literally, I understand you're gonna go back and talk to them, but can you say it in a way that assures people that starting what day? You tell me, Monday, that you can call and get answers? Can you put on there, call this number or email, like, I have in my office a list of 100 names of people who were allowed to send to, I don't want to say this too loud because council members Dinowitz and Miller and Lewis might hear me, but we have our person at OLR who we're supposed to send our 100 names to, and they will reach back to those people. I mean, that's ridiculous, right? So when can we expect there to be the Alliance to be able to answer the phone and get back to somebody within a day?
We will speak to the Alliance right after this hearing and talk to them and tell them that there must be additional service that's provided.
Can you
It may be
add
additional
this?
phone numbers, it may be, I would have to talk to them, council member, to find out what our options are.
Can you make this part of the lawsuit so the judge orders that to happen? Can you make that part of your implementation plan, that there be sufficient people answering the line?
So the lawsuit was filed against us, so.
Right, but you are coming up with an implementation plan, and I
Yes.
would imagine as part of an implementation plan, you would want people to be
Yes.
able to get information.
Correct, yes. Yes, we can do that, yes.
When will the public be able to see the implementation plan?
The implementation plan has to go first to the opposing sides.
I know, you said all this.
Okay. And when the
Is it a month, a
when
year?
the judge makes the decision, I have no control over the judge and
Has
how.
the judge set a deadline?
They have not.
Oh, wow. Okay. So then last set of questions, unless you want me to come back around to, are just about the numbers. Okay. Just real quickly, because I think I understood the answer you gave to Councilmember Dinowitz, but I'm not sure. So between 2015 and 2018, you found ways for 3.5 billion of savings. Is that 3.5 billion annually, and is it ongoing, or were they one-shots?
It was a total over the period of 14 to 18. It was 300 million the first year, 600 million the second year, $1 billion the third year, and 1.3 billion the last year.
And in those savings, are those ongoing, or are those one-shots?
No, the outgoing was 1.3 billion from that agreement.
Got it. 1.3 is baselined.
Yeah.
And what is that comprised of? That's not the $15 copay thing, is it?
So Claire, could you go through some of the details of what the incumbents
You know what I'm
do?
going to ask you to do, because we have a time limit, we have people who want to testify. I think the public is owed an answer for that. So maybe just a one-pager that you could put on your website or send over to the committee.
It is,
Councilmember, I believe that's in the reports that OLR has posted from, this will go back to probably 2019, still on their website.
On OMB's website?
No, on
OLR's
OLR's website.
those health reports
OLR,
that
and I'm sorry, what's the name of the report?
Claire,
There's
you know?
healthcare cost savings.
I'm sorry.
Healthcare cost savings?
Healthcare cost savings. Okay, great. And that report, someone up in the balcony I know is looking it up right now, and you'll text me to tell me whether or not it's up there. And then 2018 to 21, there was a second goal of an additional 1.1.
that's correct.
No, wait, there was a total, hold on. There was for the first year, it was $200 million. For the second year, it was $300 million. And for the last year, it was $600 million. The outgoing from that agreement was $600 million.
So
So
that's
1.1, 1.3 plus the 600 million for a total outgoing of 1.9 billion.
Yep. Close. Wait a minute. So the 200, no, I lost you.
Okay,
I'm sorry.
200 million the first year?
So the 200 and the 300 millions were one shots, but there was an element that was 600 million that's ongoing?
so it's not as much as it's a one shot as it is a growing period of time. So the agreement is that we would come up with $200 million in savings the first year. We would come up with additional 300 million the
So the
second year.
200 is ongoing, plus another 300, plus another 600, but it starts in different years?
The idea is that it's 200 in total savings in the first year, 300 total in the next year, and 600
Help me with
total.
the baseline
The
part.
baseline is 600, right? So 600 going out from that one, 1.3 going out from the old one, that's the 1.9.
Right, okay, so the 200 was the not baseline.
It's not baseline. The reason that the confusion there was, we don't want to say it's one shot, because sometimes we would do a 200
There
million
were
that's recurring,
components.
and then
I got
add a
you.
marginal 100, right?
Right,
You
so
know.
net, you have baseline savings of 1.9 billion.
That's correct.
Okay, and that would show up starting hypothetically in 2021?
Yeah.
Yeah, and can we find that in the same HC cost savings report?
It has not been posted yet.
Okay.
Because the numbers have to still be finalized. But we are reaching the 1.1 billion. We are reaching the $600 million recurring.
That's what you got. All right, and in that 600, I think is something you mentioned in your testimony, the $15 copay on a bunch of benefits and stuff, right?
I have to defer to Claire.
That's right, it was on page, let's see. On page 4, you start the conversation. Oh, here it is. On page 7, it says, you were talking about the timing of, you didn't want to do it right at the start of COVID. So, but there are going to be copays to certain benefits, radiological lab services, blah, blah. I think that sort of is part of the 600 million.
No, thank you for that question. I want to clarify that. Those $15 copays aren't going into effect until fiscal '22.
Yes,
So
I
they are
understand.
not part of the fiscal '19 through fiscal '21
So they're not part of this 600 million?
They're not.
Oh dear. Okay, what's the total value of all those copays? What's the savings? That'll start in January 22.
I'm sorry, I can get you an answer to that, but I don't know it offhand.
So I think this is the heart of the confusion. So we need to understand what that is, Is that the one that is remarkably the same number as the 600 million? No, I think we already talked about that, right? We already talked about that as being part of the 1.9. Now there's an additional chunk of change that will occur because of the $15 copays on a variety of services. That piece I don't think we've talked about, but it starts in, I don't think it's in your testimony, but it starts January 2022 at the same time that the Medicare Advantage program starts. I'm just describing, and they're running on two separate planes, right? Parallel, they're not the same. It would have happened anyway. But I think people are getting that piece confused with Medicare Advantage because, right, you could see how we're adding copays, we're doing Medicare Advantage, there's gonna be 600 million, which is, it's always true at O&B, there's one number that's the same number for everything. It's really frustrating.
It's ironic.
In my years, it was 80 million, but now it's like 600 million. But so the savings you're getting by drawing down more federal dollars through the Advantage program is 600 million. There will be no effect on retirees. At the same time, you have an additional savings plan that you're rolling out that includes $15 copays for some things. Is that accurate?
It's that, council member, if I could, it is not, the $600 million is going into the stabilization
Yes.
fund that
No, I
deals with
understand.
benefits for
Separate and apart.
actives and retirees.
Correct. But am I correct about there's an additional savings above and beyond the 1.9 billion that has been baselined that is comprised of $15 copays that is going to be implemented.
It's actually rolled into the 600 million, but it's a very small
Which
piece of
600
the
million?
600 million.
Which one?
The 600 million Medicare Advantage savings.
Yeah, now you lost me. I'm sorry, and I'm gonna cede back, but I really thought I understood it.
Thank you, Councilmember.
And it's, if I can't understand it, seriously, I think we have some problems. I'm not that smart, but I don't get it.
We'll provide you with a breakout of the piece of the 600 million
Councilmember.
from MA that's,
Yeah. So,
we'll be happy to provide you with a breakout of the portion of the 600 that's for these copays. It's a small portion.
okay.
Right, but I don't know if
I
it's
can
part of
appreciate
your
that.
1.9.
So-
Or if it's,
No, it does not relate to the
sorry,
1.9.
Chair.
So, let's just stay on savings for a moment, and how much do we intend, what's going to be the cost per individual or individual family do we expect to pay under the new plan?
The employee isn't paying anything. The retiree is not paying anything.
Now, what is the cost going to be?
There's a de minimis premium of about $7 per member per month in the first year, and after that, the plan is zero premium to the city.
Is what it's costing?
The city is not charged a premium after the first year, and that rate is guaranteed for, Claire, how many years?
Comparably now, what's it costing the city now
$191 per member per month.
per month? And
About
there-
$2,300, a little
And
bit.
therein lies at least a portion of the savings?
That's basically
is
the
the-
entirety of the savings.
Okay. And then, I did want to talk about the prescription drugs, some of the co-pays or whatever, but before we get there, the emergency room copay came into effect some years back, and it has increased over the years. Obviously, it's worked as a deterrent to keep people from visiting the emergency room where they could possibly visit an urgent care or their doctor. How much savings have we seen by virtue of this? And then, are we tracking whether or not folks that are not visiting the emergency room, not necessarily also visiting urgent care or their doctor, or considering that under this current plan, you may have to wait 2 weeks for an appointment and ultimately not seeing the doctor, and whether or not this is contributing to, you know, morbidity and pre-existing conditions as well, by not seeing a doctor, by what are the alternatives? And I know that there's a wellness plan. How is the wellness plan being received? What is the enrollment in the wellness plan? How do we really quantify the savings, if any, in those plans? Because are the wellness plans, the savings achieved by those enrolled in these plans, is that calculated in the savings? Because the implementation of wellness plans was part of the savings, overall saving plan, correct? And if that is the case, who's enrolled and what are we actually seeing? And in fact, are the people who cannot visit hospitals, are they being directed to these plans? How's that working? Because ultimately, we're trying to provide health care. That's our primary goal here, and the best health care possible to all of our workforce, and particularly our retired workforce. So how do we know that it's actually working? How do we, are we documenting that people are seeing doctors when they can't afford to pay a $150 copay to go to the emergency room?
Do you want to talk about wellness in general?
Yeah.
Just in general.
I'll take that. Yeah, no, thank you. There were a number of questions in there, and they were all great questions. We were really more prepared today to talk about the Medicare Advantage plan than the original healthcare savings plan, but I'm happy to talk about that program. The emergency room copay for the retirees has not changed, and I should point that out, that in the Medicare Advantage plan, it stays the same as what it was. So it's not a change there. One of the major changes that we did make to the actives plan as part of the fiscal 15 through fiscal 18 round of savings was to increase the copays for emergency room and decrease the copays for primary care. We were looking to get people to go more to primary care than to the emergency room, and looking for them to go to urgent care as opposed to the emergency room. And it had a tremendous impact on the plan. It really resulted in a great deal of savings, diverting people away from the emergency room to urgent care. We saw an uptick in primary care visits. We saw an uptick in urgent care visits, and it resulted in a lot of the savings that we reported previously.
So again, have we actually documented the primary care visits as they relate to the lack of emergency room visits? Is there a correlation between the two?
There is, and we did report on that when we reported on the end of the fiscal 15 through 18 period. There is documentation on that was shared with the committee at that time, and I can certainly resend that out so that people are aware of the impact that we had.
So, and I'm sure that budget probably reflects the budgetary and financial savings.
It did.
But again, we're here to discuss healthcare, and was there a report that says that ultimately people are better served in terms of access to healthcare because they are going to urgent care or primary care or enrolled in preventive care because of these changes?
You know, the emergency room is not the best place to go if you're not having a true emergency, not just for cost reasons, but to get the right type of care. You know, first and foremost, we want our employees and our retirees to have the best access to care that there is. And going to the emergency room is not the best access to care. Having a primary care physician that's following you and identifying the best treatment for you is probably the best care that you can get. Of course, there are emergencies where people have to access the emergency room.
Are those reports available, that the data available, that we can see the increase in primary care visits or urgent care visits and reporting data that demonstrates the correlation between healthier members and these visits?
There was a great deal of that data was reported at the end of the fiscal 18 period. I don't know that we're able to demonstrate if the overall health of the population is different. Of course, it's a changing population from, you know, among our active
because
employees.
ultimately that's our goal, to keep people healthy.
Yeah.
Right? So let us move on. So we talk about the rollout. What information had been received, or what kind of correspondence was given to the prospective retirees in relationship to the new Medicare Advantage Plus plan? What did that look like?
So in your packet, if we could refer to your packet.
Correct.
There's a 40-page guide that was sent to everybody in September and the beginning of October, that really goes through all of the details of the plan, including all the new benefits that we talked about, including all their rights under Medicare. There's a great deal of detail in here, but it's really written very, very simply.
And what confirmation do we have that this was received? So I want to thank you, first of all, Office of Labor Relations, for working with my office to help facilitate a few forums around this. But unfortunately, in late September, when we had the first forum, the majority of the folks in the room had not received this as of yet. And the people who had received it were the ones that were living outside of the catchment, traditional catchment area, the 28, 32 counties here in New York. And the people outside were the ones who received it. So do we know that people have now received it? And then, of course, my concern was, number one, was the small window of October 31st.
Yes.
Right. And number one. And number two, that October 7th began open enrollment, October 15th began open enrollment for the rest of the world. And I kind of was hopeful that this would happen and be out of the way before people were inundated with all of the other stuff and not be confused by, as I said, the Joe Namath and you know, the rest of the world that are selling you Medicare Advantage products.
Right.
That obviously didn't happen. So this would be, I guess, equivalent to a summary plan, right? That would be distributed to policyholders, describing benefits. Is there a physician's guide as well that is available?
A physician's guide, is that what you
Yeah, to let you know what physicians actually participated in the plan.
I see what you're saying.
The Alliance is working on communicating now to physicians. There's a mailing that's going to go out that I think is actually much clearer than the original mailing that they sent. They are also, just this morning, they had one of their webinars for physicians that they held with the New York State Medical Society. So they are working diligently at getting the word out to providers, how this plan is different from, say, the Joe Namath plan of Medicare Advantage.
So I personally don't find this as complicated as we're making it, for a number of reasons, but like, providers change often. Sometimes it's just a supplemental provider and you go to the pharmacy and they say, hey, I need your new card. And you say, what new card? And it's like, no, you have a new plan. And sometimes I don't know that there's a new plan. And I haven't checked my mail and saw that I received a new card and the old provider of the drug plan is no longer with us. And those are things that happen. This is far more, the consequences are far greater here. So we have to make sure that people are fully understanding that number one, that there is a new benefit, that you have to act within a certain time frame. What happens if you don't, like you said, you're automatically enrolled?
That's correct.
And there's ramifications, right? That when you sign up someone, you have to make sure that all of their doctors are accepting, all of their doctors are within this network, right? And there's a number of things that happen, right? Because seniors have multiple doctors.
Sure.
Right? And two of them might be in the network, but four of them may be outside. How do they access that information that they can make an intelligent decision about, should I stay or should I move on with this better plan?
Right, so just to start, let me start by saying that it doesn't matter if the retiree's doctor is in network or out of network. If they accept Medicare, they are covered. They will be paid the Medicare rate.
And will there be any additional costs, out-of-network costs?
No.
Just in terms of the schedule of benefits and that are in the listing, that are in the booklet, as well as in the listing of what the,
So potentially, someone who's in network now, where there's no fee, there could potentially be a fee for the same doctor
No.
under the new plan?
there's a copay. There's copay.
The copays, the $15 copays apply in the current plan and they apply in the Medicare Advantage plan. Other than that, there's no difference between what the member is paying, whether they go to an in-network doctor or an out-of-network doctor. It's the same.
So you're saying simply as long as the doctor accepts Medicare, the fee schedule is the same?
Correct.
The Medicare fee schedule is the same, yes.
Yes. And that same fee schedule would apply.
Is there something
if
that
they
binds
were
them to?
stay in their current plan as well.
Is there something that binds them to this particular plan that they have to accept the current
An in-network
Empire Medicare Advantage plan?
An in-network doctor has a contract signed with either Emblem Health or Empire Blue Cross or Anthem, which is the national Blue Cross plan. An out-of-network doctor is obligated by the fact that they are a participating Medicare provider. And so that obligates them to take the Medicare allowable fee for anybody that they treat.
Is that the same as the in-network? And if there's a difference, who's responsible for the difference?
There is no difference. There is no difference. The only copay would be the $15 copay. They can't balance bill the patient more than the Medicare allowable fee, whether they're in network or they're out of network.
Okay. Okay. And finally, on the rollout, could you talk about what you can say that you potentially can do better or differently to get this information out to retirees so that they can, so that we can expedite this? And is it the goal to get, to roll this out by January 1?
Subject to, it depends on the judge's decision. The judge is going to decide, we're going to submit the implementation plan, and the judge will make that decision, and based on what the judge says, we will act accordingly.
Are there implications for not rolling out January 1?
If it doesn't roll out January 1, it's just another effective date. It is just another, the $600 million starts at whatever point it starts.
So that doesn't mitigate the savings at all? That won't mitigate the savings at all?
There'll be a delay in the savings, because if it hasn't started, there's no savings.
So if you started in March, you prorate that and not 600,000, it then becomes...
Roughly speaking, it's easy to think of it as $50 million a month.
Okay.
Right? Every month we delay with $50 million we've spent, we're not going to get back.
Okay. That makes sense.
Councilmember, if I could say, we are available to meet and work with each of your offices to schedule education sessions, the webinars, to have people live, to answer questions. We'll do as much.
We've been very proactive, my office and and your office has been very responsive, and I'm thankful for that. And here today, we're just trying to get information out, right? Because we were trying to create a forum where what we know is that the senior population, that they get their information in person. There's churches, mosques, synagogues, and senior centers that don't necessarily have access to today. So how do we do that now? We have to be a little more creative, and this robust online presence doesn't really cut it with this population. And so, yes, I've employed my colleagues to kind of follow our lead in doing various forums and pulling together wherever we can, pull together people safely and do so. But this is really important. But I also want to say to everybody that's here and everyone who's watching that, at least from our perspective, MLC and Office of Labor Relations have been very accommodating in helping us to get this information out, no matter what it is. We've asked, you've delivered, even provided providers to come out and facilitate the meetings. How do we do that on a broader basis? Question.
Is there a plan for the Alliance to do that?
We're working on it.
Next.
Working on it, but it has to go to the judge.
No, not the education.
If you just hold for 1 second.
Yeah. Good question.
How do we expand the education to the colleagues so that they are doing their work?
Okay, okay.
Let me just answer by saying that getting retirees to understand the program is paramount to us and paramount to the Alliance. They have held so far, I think it's 77 webinars that have been attended by 38,000 retirees. We're going to continue to do that. And anyone that wants to see a recording of one of the webinars can access that through the OLR website or the Alliance website. So you can sign up for the webinars if you want to do a live webinar during which there is a question and answer session during those live webinars. But if you just want to go online and see the webinar, you can do that as well.
Are there any in-person opportunities?
We haven't done in-person opportunities, really mostly because of COVID. I think there's been a reluctance both on the part of retirees and the part
Okay,
of
so let me just say, my
staff.
mom is
But
89, and she's savvy, but she's not webinar savvy, right? And so that's the point. How do we do that? How do we do, and we've done our part. We've been safe. We've social distanced. Clearly the majority of our seniors are vaccinated, and so we've been able to do that. How do we, because if we're not reaching critical mass, and not reaching our full target audience, what are we doing?
We'll take it back and we'll talk about whether, in-person seminars on this would be more effective than our online webinars. We've had great success with the online webinars, but it's true that it's not for everybody, and we want to reach everybody in the way that's most comfortable for them.
Okay, and then the opt-out, if folks have to opt out in order to, or otherwise they are automatically enrolled. And how did we reach the 191 figure?
That's the cost of the premium. That's the current cost of the premium
That's the current cost of the
to
premium.
the city of New York.
Okay.
Anybody. That's what it costs on the open market, $191. I can go right now.
Okay.
And buy a Blue Shield and
Okay.
buy it for $191.
The senior care plan is not a plan that's on the open market.
It's an
How many,
It's an end plan. You have to.
man, please, do we know how many folks have currently opted out?
I'm sorry, say that again? Can you repeat the question, Chair?
Currently, before the litigation?
We do know that 8.9% of retirees have opted out. I think that number was as of yesterday, so it's very current.
Yeah, what is it, 23,000?
I'm sorry?
Was that 23,000?
Yeah, that's correct.
And some of us haven't opted out yet.
Okay, I would suspect that we get to ask members of the public that are here whether or not that they were kind of waiting on additional information in order to do that, and how valuable they found this information here today. And that's really why we're here, to assure people that we have their best interests at hand, and that folks are really paying attention, and there's oversight, and that the intention is to provide the best benefit as seamlessly and as efficiently as possible. And I know that Councilmember Rosenthal, who is our contracts chair, has a question, for sure.
Chair Miller, I may have two questions. I hope that's okay. So, actually, First Deputy Director Gardner, if you could just send us over afterwards the number that is the dollar amount the city would pay pre-Medicare Advantage and then what we would pay in the Medicare Advantage plan, so we can just understand that difference a little bit. That'd be great.
I'm sorry, you're saying the premium?
Yeah,
Okay.
Yeah.
I mean, yeah, sure, listen.
thank you. But I'm just a little bit curious about this opt-out business. Why would somebody opt out? I mean, as I understand what you've given us today, I'm ready to not opt out. But why would somebody choose to opt out, do you think?
We are advising people not to opt out.
No, that's not my question.
We think it's a better choice to make.
Yep.
And that the benefits are as good or better, right? And you don't have to pay the premium.
Yeah, no, First Deputy Budget Director, that's how I feel after this hearing. I get that.
I'm glad.
My confusion is around why would somebody think they should opt out, right? Because 23,000 people have. And then my question would be if they shouldn't have opted out, because now we understand that the Medicare Advantage plan is not a problem, won't increase costs to individual retirees, will the people who opted out be able to get back in, right?
Yes.
So it's all just
Yes.
very confusing. Do you understand why I say that?
Yes.
And
Yes,
even
we
the
will.
idea that, some people are saying, we were told not to opt out, so we're waiting. It's a jumble in my head. Do you know what I mean? Is there a way to clarify all this
Yes, we will clarify that. Yes.
and let folks know? I mean, what I'm hearing, I'm just gonna say it one more time, because for the record, what I'm hearing is the Medicare Advantage program will not result in any additional costs to retirees, and they will get the exact same service via Medicare. Am I hearing that accurately?
You are hearing that accurately.
Okay, so listen, I'm not gonna make a big deal of it, but it is noteworthy that there are people in the audience shouting no. And it would be helpful to help everyone feel as confident as you do. I think it would benefit a lot of people.
We will make every effort to improve the communication about the plan and make sure that everybody has an option to either opt out, or if they've opted out and realize that that was a mistake, they can opt back into the Medicare Advantage plan.
Yeah, and I guess just as the last follow-up, if you could understand this question of why would somebody want to opt out? What is it that they thought would happen, right? So I think you got a tough road ahead.
Thank you,
Thank you.
Councilmember.
Thank you for your
Thank
time.
you. And just as a matter of clarification, under current Medicare rules, when you opt out of your traditional plan, a union plan, a city plan, you don't get to opt back in, ever.
There's a yearly,
No. If you
Okay.
opt out this year, next year you can't get back in.
for Medicare, on original Medicare?
So, now,
I don't understand.
you're saying for those people who opted out, that there's a provision that's going to allow them back in?
That's right. There will be an open enrollment every year, and they can opt back. They can
So
opt.
every year they'll be able to.
They will be able to choose every year between senior care, which is the Medicare supplemental plan, and the Medicare Advantage plan.
Just those two.
Can you say that again?
So
Sorry.
what I meant
I
was if
misheard.
you
I didn't
opt
hear.
out, if you opted out and went into a Medicare Advantage program, not necessarily this one because this one didn't exist. Historically, if you opt out and you go into a Medicare Advantage, you cannot come back. You're saying now, if you opt out, you can come back to senior care.
You can come
And that's
back.
it.
Yes, you can opt
In our
back into
plan,
senior
you
care,
can
yeah.
opt back, you could opt back and forth annually between Medicare Advantage and senior care. If you decide you want to pay for senior care this year and next year you realize that
What if you opted to another Medicare Advantage and not the Medicare Advantage Plus being administered
With
by-
another vendor, another
Yes.
vendor.
Why,
Will you allow them back in?
No, can you?
if you opt out of city coverage altogether?
Correct.
If you opt out of city coverage altogether, you would also lose your Medicare Part B reimbursement.
Correct.
It would not
Correct.
be, it would not be a sensible, it would not be a sensible decision for most people.
No, so these catastrophic, whatever, would override that. But what I was saying was, the reason why we wanted to have this done expeditiously, so it did not overlap and that confusion happened, right? Where
Yes.
people took advantage of one of the programs that happened during the open enrollment season and opted out, and then, by accident ended up with some other vendor, and then next year they couldn't get back in.
Yeah, I think we'd have to look at some of these on a case-by-case basis. If people make mistakes, we're not looking
But I
to...
just wanted to be clear about the timing of this, and that people are going to be inundated with all of the different products, Medicare Advantage products, and if they inadvertently ended up in one that wasn't managed by the city, and it wasn't senior care, would they be penalized permanently?
No, they would be able to opt back in.
Okay.
We'll look at that and we will get you some clarification.
Okay, so
on that.
obviously we have
not
a
looking-
bunch of more questions, and we'll send them to the committee. We'll send them, and I will send them around to everybody on the committee and to the entire council, so that I'm sure all 51 members are being inundated with calls, so that we can get it out to our constituencies and our respective newsletters and so forth, and so that people will have the proper tools to make the decisions about one of the most important decisions that they'll ever be making, and that is obviously on healthcare, which is what made this hearing so vitally important. I want to thank you all for being here. I want to thank you for your continued partnership in this. I've been, it appears that I'm busting chops, but this is what we do. This is that important. I also want to say to everybody here that I've been an absolute proponent of an RFP around. I thought that was where the real healthcare savings exist, was within competent competition, and I'm glad to see for the first time that we now have this, and I hope that is the template as we move forward for not just the retirees but the active, that we're not just looking at savings, but we're looking at improving the healthcare quality and bringing on a much richer and larger and more qualified network. And I also am tired of seeing retirees have to come from Georgia and other places to come to New York City to visit a doctor. That's absolutely ridiculous, right? That a city with nearly a million members cannot leverage a national plan. And hopefully this is the precursor to that for even those that are in the the pre-Medicare retirees as well. So thank you
Thank you.
for joining us.
Thank you, Chair.
And
Thank you,
we'll
Commander.
call our next panel.
Thank you.
Yeah, we submit questions and they'll answer. Next up. Is Henry here?
So Henry,
Yeah.
Henry,
I'll call.
Henry,
Henry Garrido
yeah, and then Geoff Sarkin.
and Garth Sarkin.
Geoff Sarkin.
Geoff is
Okay. So we're gonna move to the next.
okay.
Keep going.
Okay, so we will.
Oh wait, he's here. Right here.
Geoff.
Got it. He's from New York too.
From where?
UST.
Okay. Anna Chapini,
From Citizens Budget.
Citizens Budget.
Jonathan Rosen
Yeah, Jonathan Rosenberg
from Independent Budget.
from IOB.
Oh, he's here. I think. Yeah, we're going through them right now. So we're calling a panelist, and if you hear your name, please come up. We. Okay, Mrs. Sarkin, you were the first up, so we will give you the mic. Please turn on the mic, introduce yourself, and thank you.
Thank you, Council Member. Good afternoon, everybody. My name is Jeff Sorkin. I am the Executive Director of the United Federation of Teachers Welfare Fund. My organization provides health benefits to approximately 400,000 lives. That group includes in-service employees represented by the UFT, retirees, and their dependents. I would note that I started my career as a teacher and rose up the ranks to where I am now. I have been employed by the UFT Welfare Fund and involved with health benefits for almost a dozen years. In my current position, on a daily basis, my focus has always been about providing high-quality health benefits that are easily accessible. I feel it is important to share with this group that I am a third-generation UFT member. I have been covered by New York City health benefits my entire life. My mother, my stepfather, my father, and my mother-in-law are all retired UFT members on Medicare. Not only did I feel a strong professional obligation in my role with the creation of this new plan, it was very personal too. This plan will be my plan when I turn Medicare eligible. I have been an active participant in the creation of the New York City Medicare Advantage Plus plan process since its inception. The big question is, why did we do this? And I want to be very clear with my answer. The money that funds all city health benefits, the Stabilization Fund, is about to be depleted. It is about to dry up. If that happens, it would be catastrophic. Together, the leaders of the MLC and the city created this new plan that preserves and enhances what we have now, and it is entitled to massive federal subsidies. Personally, years from now, it is my belief that history will show that what we did was the right course of action. I firmly believe the new Medicare Advantage plan is a superior health insurance that smartly preserves a robust benefits package that will protect our retirees well into the future. From my perspective, the only thing different with this new plan is that some procedures require prior authorization. I want to note, our in-service members have had prior authorization for many years now. The New York City Medicare Advantage Plus plan is high quality. It provides nationwide access to any doctor or facility that accepts Medicare coverage. It provides a protective annual maximum out-of-pocket on most procedures. Its drug coverage is identical to what presently exists under the current plan. It gives worldwide emergency travel coverage. It provides new health and wellness programs, including meal delivery, fitness programs, transportation to medical visits, a 24/7 nurse line, and perhaps most importantly, a formalized telehealth program called Live Health. We have all seen the value of telemedicine during the pandemic. The current GHI Senior Care Plan does not have a formalized telemedicine program. I would like to close on a vignette. Last week, I visited my primary care physician for my annual physical. My physician is a prominent doctor associated with one of the biggest hospital networks in New York City. He knows that I am involved with health benefits and that I work for the teachers union. He asked me if I knew anything about this new Medicare Advantage plan. He said he had several patients that are extremely concerned. I shared with him my involvement, and he asked if he could fire off some questions. He asked me about prior authorization during emergency situations. I told him it didn't apply to emergencies. He asked me about his patients that live down in Florida during the winter, and I shared with him that this plan is built on top of Empire's pre-existing national network, and there are many providers down in Florida. He asked me about the network size. I shared with him that there is a national network. May I please continue? Thank you. I shared with him that there is a national network of 650,000 doctors, and that this new plan operated like a PPO and would grant access to any doctor or facility that accepts Medicare coverage. He asked me, how is it possible that a plan could be this rich with benefits and save money? And I told him, being that it's a Medicare Advantage plan, New York City would now be eligible for federal Medicare Part C subsidies. He told me it sounded like a good plan. I looked at him and I told him, we worked very hard on this. Following morning, I received an email from him with my physical results. I'm not going to share that with all of you, but I also want to mention that in the email, he thanked me for my insight. He told me he had already been in contact with his patients that had concerns, and he had advised them to take the new plan. I want to thank you all for holding today's hearing. I hope I was able to illustrate that I believe that this new plan is beneficial. It will help the city save some money, and I am proud of what we put together. It is a superior health plan. Thank you.
Thank you, John.
Good afternoon, Chair Miller and members of the Committee on Civil Service and Labor. My name is Anna Champany, and I am the Deputy Research Director at the Citizens Budget Commission. CBC is a nonprofit, nonpartisan think tank and watchdog dedicated to constructive change in the services and finances of New York City and New York State governments. Thank you for the opportunity to testify on changes to New York City's retiree health care benefits. Succinctly put, we believe that this approach to financing retiree health benefits is sound and creative. However, if it fails to provide any fiscal savings to the city, and thus does not satisfy the city's legitimate need to reduce recurring spending in reasonable ways. such as bringing retiree and employee benefits more in line with those of other public and private sector workers. Eligible New York City retirees are provided comprehensive health benefits. For those eligible for Medicare, the current benefits include 100% reimbursement of Medicare Part B premiums and a choice of supplemental Medicare plans, including options with no retiree premium contribution that cost the city about $2,400 per member per year. The new program only affects the Medicare supplemental benefit. The city will continue to reimburse Medicare Part B premiums. The cost of health and welfare benefits are high, have been increasing at twice the rate of inflation, and confer significant long-term liability for the city. This year, retiree and health and welfare benefits will cost the city $3.1 billion, including $2.6 billion for pre-Medicare insurance, Medicare Part B, and the supplemental plans. The city spends another $500 million for union-administered welfare fund contributions. Retiree health insurance costs have grown an average of 5.5% a year from fiscal year 2014 to 22, and the city's current liability for retiree health benefits, known as OPEB, is $122 billion. May I go on quickly? The approach would reduce the city's cost by $600 million annually and the city's long-term liability. However, it fails to provide any savings to the city's operating budget. The agreement is to deposit the $600 million of savings into the Health Insurance Premium Stabilization Fund rather than reducing city expenditures for retiree health benefits. Spending is not reduced and budget gaps remain unchanged. The city still has to spend the same amount of money, but instead of paying for the premiums, it transfers the funds into an off-budget Health Insurance Stabilization Fund, which is jointly controlled by the city and the MLC, and provides additional benefits to retirees, and on occasion to fund collective bargaining increases or healthcare savings. Effectively, this agreement uses the reduced cost of retiree health insurance benefits to support benefits or salaries of current employees. So we believe this agreement starts off right and then veers off course to miss the finish line because the resulting savings do not flow to the city's bottom line as part of the annual budget process and instead are used to bolster other labor-related costs. Still, the change in how benefits are financed is welcome and should pave the way for employee premium contributions for health insurance coverage. Thank you.
Hi, thanks. Good afternoon, Chair Miller and members of the Committee on Civil Service and Labor. I'm Jonathan Rosenberg, Director of Budget Review at the New York City Independent Budget Office, and I'm here with Robert Callahan, who's also from my office. I'd like to thank you for the opportunity to testify today regarding the recent agreement to alter the city's health plan for retirees. This change has been presented as a source of savings for the city budget with little or no negative effect on retirees' health care. In IBO's assessment, which focuses on the budget effects, shifting the city's retiree health coverage from traditional Medicare and Medigap coverage to Medicare Part C, referred to as the Medicare Advantage Plan, provides the city with no actual budgetary savings. The plan change would free up nearly $600 million annually as the retiree health expenses formerly borne by the city are instead covered by the federal government. However, none of this savings will accrue to the city. As a result of agreements made by the city with the MLC, an umbrella organization representing the city's unionized workforce, all of the savings resulting from ending the city's financial support for Medigap insurance will be contributed annually to the Joint Health Insurance Premium Stabilization Fund. The assets of this fund, controlled jointly by the administration and the unions, are used for a variety of purposes, including the funding of unions' welfare benefits, which includes PIGA drug program, teledoc, and mental health subsidies, among others. The structure of the agreement between the city and the unions effectively transfers these city dollars from the general operating budget to a fund administered outside the ordinary budget process. This action eliminates any accountability or direct oversight for the funds by the appropriate budgetary entities. IBO supports increased transparency and appropriate checks and balances in the budgetary process as a means of safeguarding the city's assets. This transfer will effectively serve to reduce both. The city for many decades has provided affordable, quality health insurance to its employees. It's also long been city policy that upon their retirement, former city employees retain this valuable benefit. Currently, city retirees and their beneficiaries receiving post-employment benefits must enroll in Medicare once they become eligible. Historically, the Medicare population was enrolled in what is known as traditional Medicare, which provides fee-for-service coverage of hospitals and doctor visits, Medicare's Part A and B respectively. Under this arrangement, Medicare recipients pay premiums for Part B coverage, which can include surcharges for higher income individuals. Many Medicare recipients elect to purchase additional supplemental coverage that the basic Medicare Part B does not provide. This coverage, commonly known as Medigap, is administered by private providers. Until now, the city has reimbursed its retirees for their Part B premiums and has offered Emblem Health's Senior Care Medigap plan at no additional cost. Medicare Advantage, also known as Medicare Part C, is the alternative to the coverage offered under Parts A and B in Medigap. Medicare Advantage is administered wholly by private insurers who receive a per-member payment from the Federal Medicare Trust Fund to provide coverage through a network of doctors. Medicare Advantage's structure is similar to the arrangement active employees have with their health insurance providers. Members are still required to pay the equivalent of their Part B premiums, which the city would still reimburse under Medicare Advantage. As it's been mentioned, fiscal 21, New York City paid $3.2 billion for the provision of health care to its over 250,000 retirees, comprised of primarily 5 categories of payments. I won't go into each one of them, but primarily the savings that has been mentioned here is resultant from the premiums for supplemental Medicare Medigap coverage, which in the last year cost an estimated $587 million. The shift to Medicare Advantage would move this responsibility to pay these premiums to the federal government. The city has selected the Alliance, the joint enterprise between Emblem Health and Empire Blue Cross Blue Shield, to provide the Medicare Advantage plan to city retirees. The two companies currently provide Medigap plans to 92% of city retirees and their beneficiaries. The Alliance's Medicare Advantage plan is reportedly designed to be similar to Emblem Health's GHI senior care plan as possible, including access to the network of medical providers far larger than a traditional Medicare Advantage population would have access to. In focusing on the budgetary impact of this policy change, IBO has not evaluated the validity of this claim. Because there is a variation in services offered, a Medicare Advantage provider's reimbursement rate may be higher or lower than the Medicare benchmark. Any cost to the provider over what Medicare would pay is charged to the retiree as a premium. As part of the current agreement, the city has promised a premium-free Medicare Advantage plan to its retirees. The contract with the Alliance is expected to last 5 years with 3 two-year extension options. If, in the future, the Alliance determines that its reimbursement rate is insufficient to cover the cost of providing the services, the city would be faced with a decision to either renege on the promise of premium-free health care coverage, cover the excess itself, or renegotiate a less generous set of benefits. While this does not appear to pose a current threat, it could prove to be a risk to future city budgets. Both the unions and the de Blasio administration have emphasized, can I continue, sir? Okay. Have emphasized that a critical reason to move seniors to Medicare Advantage plan is to preserve the financial stability of the Joint Health Insurance Premium Stabilization Fund. The Stabilization Fund, which was created in 1984 to equalize costs between the two health insurances at the time, GHI and HIP, each of which are offered to city workers at no cost. In addition, the Stabilization Fund ensured that rates paid by the city were predictable for budgeting purposes. The city's administrative code stipulates that the city must pay the HIP HMO rate for all employee health benefits. The fund's revenues are derived from equalization payments paid by Emblem Health for years in which GHI's premiums are lower than HIP's. The fund also receives direct contributions from the city negotiated in labor agreements and earns interest on those reserves. Because of this dedicated funding stream, by 2016, the fund had a balance of $1.8 billion. The decision on how to utilize these hundreds of millions of dollars are made jointly by the city, represented by OLR, and the MLC. Over the decades, the Stabilization Fund has been increasingly used to fund supplementary health benefits and per-member contributions to union welfare funds, which can be used at the union's discretions. Because of increasing withdrawals from the funds and a decline in the primary revenue stream, as GHI's premiums exceeded those of HIP beginning in 2019, a structural deficit has emerged in recent years, as the fund's annual obligations have far exceeded its revenues. The fund's balance was $1.4 billion at the close of fiscal 2020, and just 1 year later stood at just over $1 billion. Over the last 3 years, the Stabilization Fund's average revenues have revenues have averaged $161.4 million, while their expenses have averaged $430 million. IBO estimates that at this current drawdown rate, even if annual expenses remain constant, the stabilization fund will be depleted in 3 to 4 years. The MLC and the city plan to utilize the savings from the transfer of the retiree health plan to Medicare Advantage Plus to provide the stabilization fund with an alternate revenue source. This new revenue source defers any need to deal with the fundamental issue facing the stabilization fund, the cost of annual obligations being financed with an unreliable stream of income. The agreement to move the Medicare Advantage continues to the use of the stabilization fund as an off-budget transfer of city dollars to a special purpose fund that has little or no budgetary oversight. Just to be clear, the transfer to Medicare Advantage being proposed is unrelated to the city's most recent agreement on contracts with its labor unions, as we just heard. This 2018 agreement between...
We need to start wrapping up, okay?
I'm sorry? I'll start, sorry. With the MLC and the health savings agreement to find $1.9 billion in savings, was for the basis for the healthcare savings agreement was for labor to provide partial funding of the cost of salary increases from the 2018 to 21 round of collective bargaining. But at the time of the adoption, the two sides agreed that they were going to look into things such as Medicare Advantage program savings. The city of the OLR had just...
Wrap up, please, wrap up.
Okay. OLR just recently, earlier today, even agreed that this, validated that this was not to be used as part of the savings. So in conclusion, rather than using the savings to supplement existing services or cover other recurring costs, the city plans to use the entirety of the savings to fund benefits provided by city unions. Rather than allocating these savings through the typical budgeting process, the entirety of the savings will be allocated to off-budget funds. In doing this, the city is foregoing a significant opportunity to strengthen its position in relation to retiree health costs and relinquishing its fiduciary responsibility for the expenditure of hundreds of millions of dollars. Thank you for...
So, Councilmember Denowitz, do you have any questions? Okay. So, I just, briefly, Jeff, would you, for your parents and in-laws that are retired UFT members, have they enrolled or opted out? What is their status and what have you advised them to do?
So I've advised them all along to not opt out of this program. I can tell you from the beginning when we started negotiating, the MLC and the city, and it did get contentious at times. We don't always agree. The goal was to replicate and when we could, enhance all of the benefits that senior care currently provides. I advised all of them to go into the new program. There are safeties in the new program, including the maximum out of pocket. The drug formulary, as well as the co-payment structure, is the exact same, but the monthly premium is down $25. I've told them that it's a quality plan. I firmly believe that. I hope that satisfactorily answers your question.
Thank you. Thank you. Thank you, panel.
Thanks.
Okay, we're going to go into public testimony portion. So, Sergeant, 2 minutes. And we're going to have to stick to that because we have a number of people that are waiting and the panels are limited obviously because of social distancing. So, let's call Steve Cohen. Ed Heiss.
And Lisa Flans.
And Lisa Flans.
Great. And so Steve is the petitioner's attorney and the New York City Public Service Retirees, the litigation.
Okay.
The decision came down.
Okay.
So they will have some information. You can ask them about like when's the next appearance date, like what's the...
Yeah, Lisa. I'm not answering it, but yeah. Yeah, we... Okay. Let's get started. John? Okay. Ms. Cohen, you want to begin?
Thank you, Chair Miller.